Hi, I'm Jeremy Slivnik, and I'm an advanced imaging fellow at the University of Chicago. I'm here on behalf of the Fellows in Training Fits on the Go session here at ACC, where we're talking to some of the preeminent clinical trialists here about some of the late-breaking clinical trials that are being presented at ACC. I'm pleased to have Dr. Mike Reardon with me here today. He is an endowed chair and professor of cardiac surgery at the Methodist Hospital in Houston, where he also serves as the director of structural heart disease, and has been a preeminent clinical PI on many trials in the transcatheter aortic valve space. Dr. Reardon, thanks for joining us today.
Well, Jeremy, thank you, and I'm glad to know I've been promoted to Director of Structural Imaging. Everything is imaging these days, so you're in the right field. And listen, it's a real pleasure to talk to you about this trial, which I think is very important as we move forward.
Thanks a lot. Yeah, I appreciate it. And I was wondering if maybe for our other fellows in training, if you could give us sort of a quick synopsis of the study that you did looking at structural valve deterioration in patients with surgical and transcatheter aortic valve replacement.
Sure. Well, as we all know, transcatheter aortic valve replacement has become a standard procedure for the treatment of aortic stenosis, and based on our randomized trials, it's now approved at all risk levels. In fact, risk is no longer even mentioned in our guidelines. It's just age and longevity. And so we're now seeing a lot of younger patients being referred to us that could be candidates for surgery or for TAVR. And so we need to figure out how do you sort some of these out. And one way is valve durability. All my patients ask me, the valve you put in, how likely is it to get dysfunction? And if it gets dysfunction, how likely is it to affect my health? This study is designed to answer those questions. So what we looked at was we took the randomized high-risk and SURTAVI intermediate risk trials and used a randomized cohort over 2,000 patients to look at the comparative rate of structural valve deterioration between TAVI and surgery. Then we added in the non-randomized continued access arm, which brings us to almost 5,000 patients, and used this larger group to look at the outcomes and the predictors of structural valve deterioration. And what we found was that TAVI actually has statistically less structural valve deterioration than surgery. This is the first time we've ever seen a TAVI valve show less than surgery in a randomized trial. We also found that if you developed it, whether you had surgery or TAVR, it doubled your risk of death or hospitalization. So these are really key things for us to know to advise our patients.
That's really interesting indeed. Did you notice any differences, or did you look at any of the differences between the different types of transcatheter aortic valve prostheses?
No, this trial is only the suprannular self-expanding valve. And so this should not be used to compare this against any other valves. All I can say at the end of this randomized trial is that in the population tested, high and intermediate risk, that it had either a surgical biologic valve or the Corevalve Evolute self-expanding valve, the self-expanding valve did better.
That's great. And were there any predictors in your analysis of the types of patients that were more likely to experience structural valve degeneration?
Yes, there were predictors. What we found was that if you were male, if you were older, if you had a higher STS, more prior PCI, or more atrial fibrillation, you were less likely to get structural valve deterioration. If you had a high body surface index, you're more likely to get it. So of course what that means is that women get it more often. And the other thing we did in this trial is we actually stratified by the small annulus based on a CT of 23 millimeters or less, and the difference between TAVR and surgery is even wider and statistically significant for TAVR. So if you're a young woman and you're fairly healthy, TAVR is not a bad choice.
That's interesting because prior to this, I think a lot of our energy was being focused on use of TAVR in older adults, but your data seems to suggest that there may even be more favorable outcomes with respect to the valve function over time in younger patients and females.
Well, in my clinic, I'm being referred more and more young people for consideration of TAVR. It's not unusual for me to have a 45-year-old sent in by their outside cardiologist who doesn't really understand the trials, telling them Dr. Reardon will do a TAVR on you. And that's too young. But occasionally we get to somebody that's in their young 60s who are now approaching the guideline area, and they could go either way. And we need to be able to tell them what are the pros and cons of TAVR versus a biologic surgical valve. And at least I can tell you, if you get your first valve as a TAVR valve, you have less chance of valve dysfunction and therefore less chance of death or rehospitalization.
Those are really interesting findings, and I really appreciate you joining us to give us a synopsis of your trial. A lot of the people listening to this are fellows in training or people in early phases of their career, and I think a lot of them are wondering what how do you get to where you are as a clinical trialist and, somebody with expertise in your area? Do you have any advice for any of our listeners?
Well, I've had the opportunity to serve as a surgical national PI on 5 trials now, and I've put together a lot of executive committees and screening committees, and I have people come to me all the time as young faculty saying, can you get me on this committee? And the first thing that gets them kicked off is if they don't show up and do the work. So for young fellows who are thinking about this, there are going to be opportunities, but when you get your opportunity, show up and do the work.
Absolutely. Well, that's definitely great advice. Well, thank you very much, Dr. Reardon, for joining us today, and good luck with the rest of your presentations and the weekend here at ACC.
Well, and Jeremy, just remember, everything is imaging. So the young fellows out there, it's all imaging.